Hidden behind the cornea and the iris is the unseen universe of zonules. Zonules, which give stability to the human lens. Though the frank, unstable zonules can be observed preoperatively in the form of subluxated lenses phacodonesis or can be also observed with UBM, but still the subtle zonulopathies can be seen only when you start the surgery. So in this video, we'd like to demonstrate two types of subtle zonulopathy which can be picked up during surgery. The basic anatomy of the zonular complex shows that there is anterior, equatorial and posterior zonular limb. In diffuse zonulopathy, there is phacodonesis and subluxation, but in case of posterior zonulopathy, where the weakness or laxity is limited to posterior zonules, it may not be evident preoperatively. Same is true with anterior zonulopathy, where only the anterior limb of the zonules has laxity or weakness. In a case with normal zonules, what you can observe is that during capsulorhexis, there is no movement of the lens, no folding of the capsule, stable anterior capsular rim, and the bag held by zonules gives good counter traction during cortex removal. Now let's see the first case where anterior zonulopathy can be experienced. During capsulorhexis, you can see there is no frank folding of the anterior capsule, no lens movement, indicating that there is no severe frank zonular weakness. As we proceed into the surgery, we observe that the anterior capsular rim is unusually unstable, and you can see the movement or fluttering of the anterior capsular rim here. When you notice this, there is definitely laxity or weakness of the anterior zonules, and there is always high risk that anterior capsule may be pulled during cortex aspiration. So you have to be extra careful here. Make sure you are holding the cortex and not the capsule. Use slow cortex peeling technique, and in case of severe movement of the anterior capsular rim, you can use CTR. In this case, the unstable anterior capsular rim indicates that there is laxity of the anterior zonular complex, but as there is no movement of the peripheral posterior capsule or equator of the bag, it indicates that the posterior zonules are still strong and giving good counter traction during the cortex aspiration. It is best to stabilize such bag with capsular tension ring for the long-term stability of the IOL bag complex. So after seeing this case, we'll compare it with another case, which is a case of posterior zonulopathy. To begin with, you can see the capsulorhexis appears to be going on well. No significant lens movement again, indicating no diffuse zonulopathy. Some amount of folding of the anterior capsule, but again not very severe, and there is no frank zonular weakness in this case as well. But as we move on to phaco and cortex aspiration, we notice that when we try to remove the cortex, there is posterior capsule being pulled in along with the cortex, indicating that it is not supported by the posterior zonular complex. At the same time, the anterior capsular rim appears stable and there is no movement of the anterior capsule rim. Stable anterior capsule rim indicates that zonular weakness or laxity is restricted to the posterior zonular limb here. Now we move on to the area of normal posterior zonules. you can see that the posterior zonules provide good counter traction for the cortex removal with no movement of posterior capsule in the area where the posterior zonules are strong. In the area where the posterior zonules are weak, always be careful, as if you pull quickly it can cause frank zonular dialysis or can result in peripheral posterior capsular tear. So observe that only the cortex is occluding the tip and use the cortex peel technique where you gradually try to release the cortex from the posterior capsule. Little bit of tangential movements and very slow movement of the probe is recommended. If the instability is more, one can insert capsular tension ring and then proceed with the cortex removal. All throughout, what you can observe is that the anterior capsular rim is very stable, indicating that the anterior zonular complex is strong, but the posterior zonular weakness or laxity is present. So this is a case of posterior zonulopathy. Patience is required in such cases to avoid any complication. So intraoperatively it is important to recognize this sign and take necessary precautions. Again, just demonstrating that the anterior capsular rim does not move, so the zonular weakness is restricted to posterior zonules. You can also release the cortex carefully by holding the posterior part of the cortex and release it slowly from the posterior capsule. And it is recommended to put capsular tension ring for long-term stability of the aisle bag complex. So with this video, we would like to demonstrate the two types of zonulopathies, anterior zonulopathy and posterior zonulopathy. And hopefully we'll understand better about the unseen universe of zonules.